Welcome to the IDEX Continuing Education Series.
Hello and welcome to the next in our series of continuing education topics. My name is Philippa McLaren. I'm the Head Pathologist or Pathology Services Manager here at IDEX, and I'm going to be talking to you today about effective histology sampling for pathology testing. Some of the aims of my talk will be to provide some basic rules for how to do this effectively, both in biopsies and in necropsy tissue collection, and how to sample large masses and some specific and challenging tissue sites. Along the way, you'll also find some tips on things to avoid doing in your submissions. The first thing to consider when you're submitting for histopathology is to make sure that your expectations match what is actually achievable. There's a lot to be gained from choosing the right technique in analyzing a mass or a lesion. It's important to consider whether cytology or histology is more appropriate, whether it's appropriate at all for that tissue, and whether it will make a difference to your treatment and management of the case. You might choose an incisional biopsy or an excisional biopsy, and you'll want to consider the mass size and appearance and the surgical responses to that as you plan your margins and stage the further treatment. In particular, I note at this point that there is quite a lot of value in understanding the drainage regions from different areas of the dog, and I can refer you to some excellent literature on lymphosomes, which are the drainage regions that might be the classic directions in which you might see metastatic spread from certain tumors, or in which you might expect an inflammatory lymphatic response, such as local lymphadenomegaly due to inflammation. Some of the more challenging topics include decalcification of bony tissues and management of things like autolysis or genuine necrosis in the tissue. I also want to talk about diagnostic sensitivity and specificity because we tend to forget that histopathology is a diagnostic test, and as such, it has some limitations. It's never 100% sensitive and specific. No one test is. And the pathologist experience and quality of the reporting and a whole range of factors will tie into that, not least good sample selection. What we really want to hear from you as the pathologist sitting in the lab is, what have you taken? What is the background? How is the animal performing, behaving, or responding to treatment? It's important to give us as much information as you can and avoid the dogma of giving the pathologist nothing so you don't bias us. Completely incorrect. We really do value the information that we get clinically. We want to know the age, the sex, the breed, and if relevant, things like production status. We'd like to know the systemic signs. We don't necessarily want 10 pages of history that relates to vaccination and dog food sales, but if you can summarize for us in a brief form, that is very, very much appreciated. Information on what you've given the animal already and what the environment might mean for this lesion or condition is very important, not just for production animals, but also for our exotic species and our companion animals. Pathologists love to get pictures, radiographs, CT scans, MRIs, and we're not very good at interpreting those, but we really love it when we get both your interpretation of that or the radiologist's interpretation alongside the images. A picture does tell 1,000 words. Down the bottom of the screen, you'll see an email address, and we use this email address for clients to send us the information, the pictures, the additional supporting documents that you might want to attach. We don't monitor that email address, but if you write the patient's name in the subject line and then on the submission form write, "I have sent pictures" to the case info email, we'll go looking for them in that unmonitored email box. And it seems to be the best way we have at the moment of getting those pictures to the pathologist. In relation to the lesion, we want to know where it is, how long it's been there, the location in relation to anatomic structures, size and shape, color, sometimes smell. All sorts of factors will be useful in interpreting that lesion. Incisional biopsy sampling is a cost-benefit analysis that you as the clinician have to make every time. You might choose an incisional biopsy to better plan the subsequent surgery, and that's an obvious decision when the surgery is very challenging or when margins are going to be difficult to achieve. You might choose it to know better what the process is, whether it's inflammatory, neoplastic, or something else. So when you're collecting and you've chosen to go for an incisional biopsy, A few things that are important, and pathologists, we're not the best people to advise on this because we don't have to deal with the patients, but we certainly understand that the representation of that sample is important to us and therefore to your diagnostic protocol. Getting a representative sample might mean taking part of the center, part of the edge, a representative cross-section of a lesion. But it also might be compromised by the need to consider the ability to completely excise a neoplasm. You've got to think about the coming surgery, hopefully for excision or repair. You've got to think about possible radiotherapy and other effects of the local wound site. It's important with an incisional biopsy that you make sure that the tissue is not going to miss the relevant part. For example, if you have something like an epithelial tumor that is surrounded by inflammation and a lot of fibroblastic response, that might not necessarily respond well to an incisional biopsy. A mammary tumor might not respond very diagnostically to an incisional biopsy because it varies significantly across the tumor. Soft tissue sarcoma is the one I particularly find challenging to grade on an incisional biopsy, and that's largely because they vary so much as they grow. Different clonalities develop within that tumor. Some areas may outgrow the blood supply and become necrotic, but of the three grading elements, one of them is the percentage of necrosis, which varies depending on which bit you pick, and that might bump it from a grade 2 to a grade 3 with a very significant consequence for the management of that lesion. So sometimes the limitations of an incisional biopsy is not as specific as you might like. One of the other things that people tend to forget is that when you are collecting a sample and you've gone as far as putting the animal under an anesthetic or a sedation to do that procedure, you don't necessarily have to submit everything that you take. You can put stuff in formalin and leave it there. You can come back to it later. You can put it on the shelf. It will last for a very long time. The only corollary to that point is that immunohistochemistry can be affected when formalin fixes the tissue for so long that the proteins cross bond, and then your ability to go back and do specialized testing might be limited. So collect it while you're there, if you can do so reasonably without compromising the patient. If you've gone so far as an exploratory laparotomy, take multiple organ samples if you can. If you're investigating a gastrointestinal condition, taking full thickness biopsies from several locations with the compromise for surgical time and risks to the surgical sites. Full thickness biopsies give us a lot more information. Mucosal biopsies tolerable. We certainly get a lot of endoscopic biopsies and we do what we can with them. But that full thickness gives you information about so much more of the tissue. While you're there, did you want to consider taking a little bit of the liver, the regional lymph nodes, a bit of the spleen or the whole thing if there's an obvious and significant mass, even the kidney and pancreas? There are elements of challenge associated with some of these organs, but there's plenty of good literature about how to do these things effectively. With an excisional biopsy, as with an incisional biopsy, the formalin ratio is really important, and 1 to 10 seems ridiculous when you think of the size of a typical soft tissue sarcoma excision. The mass might be 10 centimeters cubed. That means you need a whole liter of formalin to fix that adequately, and people tend to neglect that. When you have a very large specimen, it's a good idea to start off the fixation, and if it's bloody or if it's not fixed in quickly, you're not going to get a faster diagnosis by sending it to us that day. We're still going to leave it on the shelf to fix for longer. So don't feel that you need to be in a rush. Fix it there, throw away the first batch of formalin and put some more in if it's bloody and particularly relevant to spleens. That is worth having several pots, and it's worth preparing in advance because you never know when you might find yourself trying to take out a very large organ or submission and not having an adequate pot available. A few buckets from Bunnings. We can supply buckets of a reasonable size. Make sure you have them on site. If you get desperate, send them out for ice cream and eat the lot before you have to start. And then fix it in that and then transfer it to a decent tub once you have one available. If you find yourself at surgery and you want to, you take the mass out and then you look at your surgical site and think, I'm just not happy about those margins, I'm going to take a deeper excavation. I'm going to take another layer of fat, or I'm going to come down another layer into the fascia of that muscle. Take that piece of tissue that you have taken that's less obviously attached. It might be completely separate, and once it's formalin fixed, we won't know which way is up. which way is our deep surgical margin, and which way was facing the first excision tissue. Use some suture thread, not the needle, but just a suture thread, a couple of sutures on one side, and then tell us which side you've put them on. That's one way to handle it. Put it in a separate pot so we don't miss it or it doesn't all fall apart as the other tissues fragment, particularly important for things that are fatty and have separation of fascial layers. Once you've got that really large specimen, there's a way of trying to keep it together so that the pathologist or the scientist can select the sites, but that you can still make sure it fixes. It takes a full day to get nearly a centimeter of tissue fixed. And you can imagine that in a very large specimen, that's going to take a long time. The garlic bread slicing is my way of explaining we want you to keep that architecture intact, but get slices through it so that you can get the formalin penetrating into the lesion. Difficult with spleens, they will tend to fall apart. They often have large lakes of pooled blood. But do your best to ensure that you've got that compromise between architecture and fixation. If it falls apart, 2 separate pots. This is the bit I'm worried about. This bit is less concerning. Label it all up and then make sure that that communication is come to us. You can also photograph the lesion, and we can then look back to that as we look at the fixed tissue when everything has shrunken and become brown and leathery. If you've got to send things by freight, you might need to consider the volume. And if you've, for example, taken a leg off or a very large organ or necropsy specimens, fix it in the clinic. It might take a week to fix that tissue. It might just take 2 days. Once you've fixed it, you can then submit it in a smaller volume of formalin or wrapped in paper towels that are moistened with formalin in a small bag, adequately sealed, multiple layers. And you could also select the bits that you think are relevant and send just those, but it's a good idea to keep the rest. Provided you've got some reasonable storage space where formalin fumes won't be a problem, you could submit the bone of a fracture case where you might want to rule out osteosarcoma, for example. Keep the rest of the leg in case you feel you need to come back. Or you might submit a few pieces of the spleen and then submit the rest if those are non-diagnostic. Margins are something that causes a lot of confusion. You've got to remember that when we're looking at histology, we're looking at 2 by 3 centimeter at most pieces of tissue, each of which is only 4 microns thick. And to achieve those sections on glass, we're cutting something that is less than 3 millimeters thick to put into the block. So it's a tiny amount of the tissue that we can possibly examine. For example, when the human medics and pathologists are doing cut-ups for certain excisions, they might take 100 glass sections and charge appropriately to look at that many pieces of glass. That could take one pathologist a whole day. And so you've got to remember that your margin is the best representation of the tissue that we can achieve in a reasonable manner, providing you the fastest service that you want. It's easy with something like this intussusception. We can see where the lesion is. We're still going to cut it up, and it's obviously an intussusception for those that have had to deal with them surgically. But we want to look at the proximal and distal margins. We also want to look at the area of relevance, and we'll try and look for lymph nodes that are involved in that process. And the scientists are all well trained to understand the anatomy of the tissues, but they also value more advice and information. The pathologist will step in and have a look, but you having access to the wet tissues can often advise that best. So take the bits of interest. The surgical end of the limb, when you've done an amputation, is a challenging one. In general, the rule goes that if there is more than 1 joint distance and you've amputated proximally, the lesion is more than 1 joint distant from that excision, then there's not really any point in doing soft tissue margins. If it's more than 2 centimeters from the soft tissue margins, the same is likely to apply. Some things like soft tissue sarcomas will tend to have tendrils penetrating through, and those can work their way up along the fascial planes. So we do try and take surgical margins when they seem relevant. We'll always try and find the lymph node, but that can be quite challenging. And depending on your need to create a skin flap to close the wound, you might have taken that node already. If you find it, incidentally, while you're cutting the leg off, then send it in a separate pot. That's a good idea. The other thing that you can do for us that really helps with the speed of the diagnosis, bearing in mind that in the lab we don't have a full post-mortem suite, no more full post-mortems occurring in commercial diagnostic labs in Australia. And so you're the one sitting there with your surgical tools. You've just done the amputation. Perhaps before you clean the kit, you might just take off some of the muscle, which really isn't relevant in most cases, and just send us the bone itself and the immediately relevant pieces. If you've done a large mammary strip, that might require several pots so that you can adequately fix it. If you make sure that you label the bits that are relevant, that can help us. For example, if you take a length of tissue and you slice it into 3 pieces, when we take them out of the formalin, it might seem like the middle ends of those cuts are part of the surgical margin, but they're not. Those are the cuts that you made at the time of surgery to get it into the pots. So help us out by trying to indicate where those relevant margins are. If you feel an area is particularly concerning, highlight it with a suture. Here's an even better way of going about it, and this is what we do in the laboratory. You can actually take special ink or dyes, including things like tattoo ink if you're really desperate, to highlight the areas of relevance. The way to do this is to take the tissue off the animal and allow it to dry a little bit, maybe blot it with some tissues on the bench and blot it until it's not damp anymore, or the blood's gone. Once it's dry and tacky to touch, you can paint it with ink of varying colors, and that ink, if you allow that to dry and blot the excess off, will then stay attached to the tissues when it's in the formalin. So you ink and then you put it into formalin. You could at the same time be cutting some pieces that you consider to be particularly relevant, or you could be taking surgical suture thread that's left over from the procedure itself and using that to indicate to us the areas of relevance. What I would implore you not to do is to stick needles through it to highlight. I've had that happen a few times, and it seems all well and good at the time, but when you remember that the tissue in the formalin has now become brown and shrunken and the formalin is now colorful, the scientist reaches their hand into that pot and they might get a needle stick injury, which would be quite concerning. Bones. Bones are a particular challenge for us because of the need to decalcify. We have to get that just right. There's a balance between able to cut and completely missing architectural structure on histology. So if you can make sure that you're aware and you have informed your client that it's going to take some time, sell that bone out if you can. That's going to make it faster for us. But we still have to formalin fix before we decalcify. So it goes through a 3-stage formalin fixation, then decalcification, and then processing. If you're going in to take an incisional biopsy from a lesion and you want to avoid causing a pathologic fracture yourself, you need to try and aim for representative sampling. If the bone is a concern for osteosarcoma or osteomyelitis, that might be quite simple in that you're going through the softest part. You want to try and get as deep as you can, sometimes right the way through to the marrow. And it's important to avoid just taking the surface, the periosteal reaction, because that always looks pretty wild. And on histology, it can be very challenging to differentiate an osteosarcoma from a really exuberant fracture callus. And the same applies to cytology. For cytology, the only benefit of bone FNA when you're concerned about a sarcoma or osteomyelitis is in differentiating inflammation and neoplasia or reactive. Can't really go much further than that. When you're taking true cuts or Jamshides, give us more than one if you can. The more you give us, the more likely we are to be able to get a diagnosis, bearing in mind the clinical limitations. Skin is a real challenge, and we have some special guidelines that have been created by our skin specialist, Dr. Mandy O'Hara, in our directory. What we need to know is what's going on for the patient. If you can at least tell us when you've required steroids to get the patient's comfort level manageable, just tell us how long and for how, what dose relative to the size of the dog. No point in telling me it's 5 mg if you don't actually tell me how many kilos that dog is. Tell us if you've given antibiotics, and sometimes it's appropriate to do that beforehand to avoid the secondary infection. A notable example is in nasal planum disease. There's almost impossible to tell histologically bacterial pyoderma from some of the inflammatory and immune-mediated conditions when there is severe infection. So it can really help to control that. The longer you leave a skin lesion, the more chronic and secondary changes occur, and that can necessitate wishy-washy histopathology reports that we would prefer to be able to narrow down. So it can help to do some sampling relatively early in the course of the disease. If you can avoid patient-induced lesions, lick dermatitis and secondary trauma, that can help. And don't forget, we don't want the crust removed. The crust is useful, and so your preparation for skin sampling is relatively limited. Call us for advice. All the anatomic pathologists are very willing to give advice on how to sample, and if you can send us a picture, we might actually do this for you and highlight what we think are the best areas to have a go at sampling. Obviously, a very big lesion like this, you can't sample a whole range of tissues. The whole thing is not coming off this dog. But we can give you some ideas on how we might choose to sample that if we were the one taking it. If you're going to take multiple sites from a dermatology case, you might want to consider putting them in a single pot per site and labeling them as such. The thickness, the density of hair, and many other features will vary by site. Punch biopsies are important because they're very simple to take. You can often do it in a conscious patient, minimally traumatic. It might be relevant to show animals in particular. The very small punch biopsies can be very challenging to read because the edges of the punch are torn apart. And particularly for things like papular diseases, you might find that that is essentially ruining all diagnostic material. So a larger punch biopsy is preferable to a small one. And if you can go further than that, an ellipse or a wedge might be much more pertinent. Try and aim to give us a selection of the affected tissue, right from the margin through to normal tissue and to the most severe areas. Minimize the site prep. Now that might mean just clipping the very superficial hairs. It might mean a tiny alcohol rub for a punch biopsy. If you're having to do a full surgical scrub, you're going to lose the crust. So be aware of that. Handle the tissues as if it's paper towel, really very gently. The tiniest of forceps, the most gentle rolling into the formalin pot. And give us those photos and the full history. And again, there's that email address for you. Digits. Now, this is a real challenge. There is a wonderful paper that I've referred to so many times now, and it's written by one of my colleagues just down the road. This is a technique for biopsying nail bed when you have a diffuse nail bed disease or a single site. If it's a single site, you might well choose to take the whole digit. But for conditions where you're interested perhaps in fungal keratitis, or if you're worried about symmetrical leukoid onychia dystrophy, I always have to look up, you might choose to do this nail bed biopsy technique. Basically, it uses a punch biopsy and goes along the plane of the P3 into the nail bed. I'm sure you don't want to be doing this conscious. The liver is a challenging organ. People are very concerned about sampling liver, and with good reason, because if you have liver disease, there's often concern about liver function. So that might include hypoproteinemia. It might include concern for coagulation, enzyme production. So you might consider an FNA, and I can give you some reasonable information on an FNA for cytology. I might be able to tell you if there's a diffuse inflammatory process, if there's a diffuse infiltrate, or if you get lucky and the lesion is a mass in which there are particular features of malignancy, I might be confident to give you a diagnosis of neoplasia. But many times the liver tumors and nodular hyperplasia look essentially the same on cytology, and a true-cut biopsy isn't necessarily much more value. The important thing is the architecture and the whole organ wedge structure of the portal triads and their interrelation to the vasculature, to the hepatocytes, to the biliary tract. The bigger the specimen, the more likely we are to get more information. Pathologists would always like the whole animal. In our case, we'll happily settle for a wedge, or if you're taking out a lobe, for example, because of a mass, send us the whole thing. It can be really challenging to sample the right bit of that, and the differentiation between a hepatocellular adenoma and a hepatocellular carcinoma can come down to how it behaves at the margin with the normal tissue. This is an example of a wonderful picture that one of my submitters sent to me just a couple of weeks ago. This was a spleen, and the question was, how do I sample this spleen to get it to you? Because I have to freight this by air, and I can't send the volume of formalin, and I don't have a bucket big enough for this thing. You can see it's really rather substantial. So I sent back a picture with some suggestions on where I might take some samples. And the suggestion was basically collect a range of these things. Stick the whole lot in Formulan once you're done. Send us those little bits in 2 pots, the normal spleen bit and the mass bit, so we can tell them apart more easily, particularly at those 2 down at the base of the lesion where the spleen merges with that mass. But stick the whole thing into a tub of Formulan to keep fixed. And if you can make a couple of good slices into it, that will help. You'll also, as I said earlier, need to change the formalin in that pot because the blood deactivates it. Now we come to necropsies. For those of you who aren't regularly doing necropsies, you can finish here because that's the end of the biopsy section. But if you're planning or unexpectedly find yourself with a surgical disaster or a need to open an animal up for insurance or for clinical investigation, the size of the specimens that you send us matters just as much for necropsy collection as it does for biopsies. Anything more than 1 centimetre in thickness isn't going to fix. And so you can collect a whole range of specimens, send us some pictures, and send us the organs in, ideally, pots labelled with site. Now, you don't need to send us 20 pots of different things. We can tell what most of the tissues are after the event, but it's a good idea to separate out a pot into areas of particular interest. So, for example, if you saw a little bit of pancreas that just looked a little bit unhappy, maybe a little bit inflamed, and you just wanted to know if that was relevant, well, stick that in one little pot and stick the other things in another pot. Perhaps you might go so far as to take the brain out if you suspected neurological disease. Don't forget the spinal cord. And that might be into a 3rd pot because the brain is quite fragile. You might also be cost constrained. So you can submit pots and label them by order. And you can tell us, sample pot 1, hold the rest. And we'll happily hold them for months. You can then wait for your first histological diagnosis. And if it's diagnostic and you have enough information, that's done. But if not, you might then choose to go back to the pot again and we'll get the next tissues and sample more. And then your bill will extend. But we're happy to do that because we understand the process of trying to minimize the cost to the client. If you have lung and it's floating and you feel that you need to put the paper towel over the top to make it fix well, that's great. Generally, the rule is if it's floating, it's pretty good. This was a sample of an FIP cat that I saw many, many years ago in the very early stages of my residency. And I put it up there and PowerPoint decided it would do its annotation. And it told me it was a close-up of a hot dog. I'm very glad it's not. Now, moving on to some fun stuff. If you are sampling post-mortem samples from small creatures, really genuinely small creatures, the easiest way to do this is to simply open the cavity or the coelom and have a look, see what you can see, maybe collect the samples that you might need for culture or for molecular diagnostics, and then stick the whole thing opened into Formulan. And then that will now fix all the way through the body adequately and enable us to go in and take our samples. So with a little fish, we can do serial sections of the whole body onto a slide. You can get a zebrafish, a small one, onto a slide in a full longitudinal section. You can also, for example, take a frog and put its toes perfectly aligned onto the slide so you can look for chytrid fungus. Puppies and kittens are just too big for this. So you can't do that. You can't submit a whole puppy in Formulan because you're going to find that it's not going to fix well enough. So you're going to treat them like a regular post-mortem. You're just not going to get much out of the gross examination. So have a look by all means, but just take representative samples and we'll come to what those might be. The CNS. There's a particular joy and challenge in taking brains and spinal cords out of animals, and that can be very challenging. It's something that there are plenty of techniques, and I don't intend to tell you how to do the brain removal, but what I will tell you is submit the whole brain. If you need to bisect it or if it's fallen apart during the process, just toss it all in a big wide mouth bucket. If it's an abortion situation, you might still find that as you pour that liquefied brain out of the brain cavity, it looks like it's not going to be diagnostic, but it's amazing how often that is the case. You might pour it into a paper towel and then gently fold that up and put the whole lot into Formulan, and that will still fix very well. Now, we're not neurologists, but we do understand some of the neurological science that relate to particular areas of the brain, and we have a good range of books. So tell us what you've sampled and tell us what you've seen clinically so that we can choose the site as we cut the brain There are standard sites that we might choose, but if you tell us that the lesion is a particular presentation, we will go looking for that trigeminal nerve root or whatever is the relevant part. If the brain is very, very large, so if you're submitting a cow brain and you're doing TSE exclusion, you might want to gently separate the corpus callosum just to allow the ventricles to open up a little bit, and then that formalin can penetrate the ventricles and reduce the fixation distance. And don't forget that anterior spinal cord. Now, abortions, there's plenty of specific testing to do for infection detection in whatever species you're dealing with, and there's good literature about how to choose those. But here's a general rule. Always try and get the placenta if it's available. And for example, in a horse, there are different specific areas of the placenta that you would need to sample. And of course, you're going to be wanting to check it's intact. In regards to the fetus, you're going to want a full range of organs. And this is your general rule down the right-hand side. Lung, liver, spleen, kidney and heart. Thymus, because it indicates the immune status and the developing lymphoid system. Adrenal, because certain species have a particular characteristic vasculitis there. Brain, particularly important for some of the developmental diseases. And eyelids for BVD. That's a weird one. Just cut straight through the conjunctiva and the skin. You can also at the same time collect that body ooze that is around the heart. We're not going to call it necessarily heart blood. Sometimes it's clotted, sometimes it hasn't. We might be collecting pericardial fluid or just the goo that sits as we open up this liquid fetus. Collect the damn serum. You might not test it now, but you can separate it, freeze it, or keep it in the fridge until it becomes relevant. Collecting the stomach content gives you an overview of the amniotic fluid because the fetus has been drinking that and passing it through the gut. And that can tell you very well what the status of the amniotic fluid was, whether it's got bacterial or fungal pathogens or something else. Collecting the placenta gives you an idea of pathogens that are targeting the placenta. And collecting the liver or spleen from the fetus gives you an idea of what was circulating in the fetus's blood because those organs are very vascular. So they give you an idea of what was causing a septicemia. I hope that's been informative for you and that will help you with your selection guidelines. Plenty of resources out there, and the pathologists are always available on the phone to talk you through postmortems. My very strongest statement, the benefit of those photographs and the communication that you give us will greatly enhance what we can give you back as a diagnostic tool. Thank you very much for listening.